So welcome everyone to the 8th TIA Centre seminar of the academic year. And for those of you that are new to our seminars online, we try and invite people from across the world that are doing new and exciting research. And today we're really excited to be joined by Dr. Asmaa Ibrahim. So Asmaa is a qualified medical doctor and pathologist who started her journey in the UK at the University of Nottingham and under the mentorship of Professor MAI and MCT. During Asmaa's PhD, she acquired diverse skills in research methodology, statistical analysis, student supervision and teaching. And inspired by digital pathology's potential, Asmaa joined the Pathway-funded digital pathology team. Their mission was to develop a robust algorithm identifying which ER-positive or HER2-negative breast cancer patients would benefit most from adjuvant chemotherapy. Collaborating with computer scientists at Warwick, Asmaa successfully provided data and annotations for machine learning algorithms, producing high-quality research articles. Asmaa's journey stands as a testament to the powerful synergy between traditional medical expertise and cutting-edge technology in advancing cancer research. The title of Asmaa's talk today is Practical Applications of AI Models in Mitosis Scoring. And yeah, with that, Asmaa, feel free to carry on with the presentation. And we're really happy to have you here today. So thank you so much for joining us.
Thank you very much, Adam. Good afternoon, everyone. Today I'll be presenting about artificial intelligence models and their clinical application in practice. So why mitosis is important? Mitosis is a reflection of the tumor proliferation. And tumor proliferation is one of the most powerful morphological prognostic parameters, and it is very essential for assessing the tumor growth rate and assessing the patient prognosis. In breast cancer, and as well as many other tumors, proliferation is assessed by counting the number of mitotic figures in H&E sections. It is a very easy and cost-effective technique. In literature, different techniques have been proposed to visually estimate the mitotic counts. These would include the mitotic index, which is the ratio of mitotic cells to non-mitotic cells in a certain area of a tumor, and it usually reported as a percentage or a number of mitotic cells per 1,000 neoplastic cells. This was proposed to account for the variability in the tumor cellularity. However, it is very hard to count the number of mitotic figures and the corresponding tumor cells, so it is usually not applied. The second technique was the mitotic count per the whole tumor, which would be counting the number of mitotic figures per the whole tumor area. This, of course, would alleviate the subjectivity of choosing the area of where to count, but also it is very hard and time-consuming method. The third technique would be the mitotic activity index, which is the counting of the number of mitotic figures in a specified area of the tumor that would reflect the whole tumor area. And it is usually provided as an index, which is the mitotic count per the area counted. And then, however, none of these techniques have been proven to outperform the others in a large-scale study. And as we are having the super intelligence techniques that can count mitotic figures within minutes, if not seconds, so we proposed why not assessing all these techniques and identify which would be the best to score mitotic figures in using AI in the clinical practice. So first, what are the morphological features of mitosis? The basic morphological features of a cell in a mitosis are this, as you can see in this image, this is a hyperchromatic nuclear material, and the characteristic alignment of the chromatids in the neoplastic cell. As you can see, the mitotic phases has different phases, which are the prophase, metaphase, anaphase, telophase, until it eventually divide into two daughter cells. So the first prophase is where the whole chromatin are clumped in the center of the cell. In the metaphase, they are aligned as straight rods in the center of the cell. Then they begin to be detached into two daughter cells, and finally the telophase is the final separated two cells. Also, as you can see, there may be absence of the nuclear membrane. There is no regular nuclear membrane, and the chromatin appear like a hairy-like extension in each of these sections. There are also typical forms of mitotic figures. These are not the typical that we can see. These atypical forms are commonly present in the highly malignant tumor cells. Like they have different three pools, like this one, the tripolar, the quadripolar, the multipolar. This is where this is alec type mitosis. This is polar asymmetry. This is anaphase bridging. This is ring mitosis, and this dispersal mitosis. These all are atypical forms of mitosis, but can be seen in a highly aggressive malignant tumors. So as we have seen, there are specific morphological features of a cell undergoing mitosis that reflect the tumor proliferation. However, in real life, there is substantial inter and intra-observer variability. This first could be attributed to the presence of many cells or many structures that can mimic these mitotic figures. As we can see, these figures can be hyperchromatic, as here, maybe having the characteristic alignment within the cell, but however, these are not mitotic cells. These can be stromal cells, some crushed cells, some artifacts. So the morphological identification of these mitotic figures and the different phases is very essential for agreement between pathologists, and it can cause a significant inter and intra observer variability within when we score. Beside the morphological factors, there are other factors such as area selection. There are different areas proposed to count mitotic figures within. Some propose 1 millimeter, other propose 2, 3, 4, up to 5 millimeter area. Also, the area chosen they are representing the highest proliferative features or highest proliferative area within the tumor, or the periphery of the tumor, or random selection of random areas. All these contribute to the significant inter and intra-observer variability. So different approaches in counting have been proposed, such as random and non-random techniques. In the later, pathologists can selectively choose the area with the highest number of mitotic figures, which we call hotspot areas. And the CAP, which is the College of American Pathologists, have recommended that during reporting, mitotic figures should be counted in a particular number of consecutive non-overlapping fields, using microscope in the peripheral part of the tumor, as they assume that these are the areas where the highest number of mitotic figures, or as we call the hotspot areas, are present. Researchers have tried to identify some molecular markers that could reflect the proliferation of the tumor and the mitotic figures. One of these are, of course, the Ki67, and here this is an example of a marker known as PHH3. This marker can accurately define and identify the mitotic figures or the cell undergoing mitosis in a slide. However, some would argue, and a lot of pathologists argue, that this is very cost effective, very not cost effective, very costly, and it's not feasible to cut and stain each case with this marker just to count mitotic figures. So we are trying to search for a more cost-effective method. And of course, we have the AI algorithm, or the machine learning algorithm, that can count mitotic figures with in a very efficient way, and it's easy and most cost-effective techniques. And it has been attempts have been ongoing to automate the counting of mitotic figures. So in this study, our aim was to determine the optimal mitosis scoring technique, either use the mitotic index, mitotic activity index, or mitotic count for the whole tumor using AI algorithm, and evaluating them for survival prediction in comparison with the visual scores. This could provide an insight into the feasibility of using these automated techniques in clinical practice. So initially, our study involved two large cohorts. It's the first Nottingham cohort and an external validation cohort, which is the TCGA cohort. In the Nottingham cohort, we split the cases into a discovery set where we identified the cutoff points and an internal validation sets where we tried our cutoff points on, and of course, external validation cohort. For developing the algorithm, we, a group of pathologists from Nottingham University, have used an online annotation tool, which is Wasabi, to annotate different mitotic figures, exclude different mimickers. We were a group responsible for annotation of these figures. For each case, 2 pathologists were assigned to annotate the mitotic figures within the whole slide in a blinded manner. Any cases that shows disagreement were re-evaluated by another pathologist to establish a consensus on the data sets. Finally, a total of 7,960 mitotic figures were finally annotated. This is how we annotated the whole slide. Oh, of course, there were cell level annotation and architecture annotation. We annotated every structure within the whole slides, including the mitotic figures. And for the algorithm development, the mitosis detection algorithm developed by Mustafa is a 2-stage framework. It consists of candidate segmentation and candidate refinement stage. In the candidate segmentation stage, he used a convolutional neural network to segment mitotic candidates. Excuse me, and to train the segmentation network, mitosis mask was generated, which is based on the pathologist coin annotation and the interactive annotation tool, which is NeurClip. The candidate refinement stage was performed using a deeper classifier. The algorithm used in our study, which was developed by Mustafa, has been validated extensively for mitosis detection in various cancer images, and it has ranked the first in Medical Challenge in 2021-22. This dataset has been curated based on the visual mitosis and mimicker annotation. We have corrected some of human correction has been applied, and in cross validation, the algorithm has achieved an F-score of 0.9, a sensitivity of 0.89, and precision of 0.97. For the identification of the hotspots, a framework has been also developed by Mustafa using a greedy search algorithm by employing a tissue segmentation convoluted neural network from TIA toolbox. This algorithm identified the mitotic hotspot region within the whole slides, which is defined as the window contains the highest number of mitotic figures and was indicated by the red color. I'm sorry. This is like this picture show the framework of how we did this. This is the part where we annotated the mitotic figures, and then the segmentation, and then the identification of the hotspots using the greedy algorithm. Then lastly, the mitosis scoring approach, the number of mitotic figures were scored using the algorithm, and we scored this through 3 different techniques, which is a mitotic count where the whole tumor, where we counted the whole mitotic figures within the whole tumors and then divided it by the number of by the size of the tumor, and then the mitotic index. We first employed a deep learning nuclei identification model called Hoover net, which was developed by Neural. It was used to quantify the number of malignant tumor cells present in each slide, and then we calculated the average number of mitotic figures per 1,000 neoplastic cell. Finally, the mitotic activity index was calculated by counting the number of mitotic figures within a 3 mm hotspot area. It was carefully chosen to only include the invasive tumor cells, avoiding any areas of stromal cells or DCIS. Finally, the 3 approaches were compared. We wanted to choose the best approach where we can use in clinical practice. So we tried to evaluate and compare all these approaches according to the correlation with the clinical pathological parameter, the correlation with the visual scoring method we use in clinical practice, the Ki-67 score, the patient outcome, and chemotherapy prediction. Okay, just to confirm the reliability and the producibility of the automated scoring detection, we visually counted mitotic figures in 400 cases from Nottingham cohort and 757 cases from the external TCGA cohort as a continuous count, and then we compared our scoring with the automated score derived from the algorithm. So then, regarding our results, first, the automatically derived mitotic counts for all different and all showed unimodal distribution. We converted each count into 3 scores with 3 different cutoff points based on the breast cancer survival. As you can see, for mitotic count, we divided all the count into 3 scores. The same for mitotic index, the same for mitotic activity index. All the 3 were different, of course, and all showed unimodal distribution. Then we correlated these scores with the clinical pathological features, and we have seen that all the whole 3 scores were significantly associated with aggressive tumor behavior, like high nuclear polymorphism, larger tumor size, and high Nottingham prognostic index. And this also highlight or emphasize that the mitotic or the rate of proliferation is highly associated and correlated with the aggressive features of the tumor. When we applied the same cutoff points on the validation cohorts, we're using the same cutoff point. We have found the same results. All the high scores from all the 3 different techniques were highly correlated with aggressive tumor behavior. Then we correlated our scores with the scores derived from the algorithm with the Ki-67 scores. And interestingly, we have found that all 3 scores were correlated with, only mitotic activity index and mitotic count per tumor were significantly correlated with the Ki-67 score, while the mitotic index was not. Then we tried to correlate our score using visual assessment with the 3 different scores, and found that mitotic activity index and mitotic count per tumor were significantly associated with our visual assessment. The same results were observed in the TCGA cohort. Finally, for the prediction of the patient outcome, we have found that using univariate analysis, that high mitotic count per tumor, high mitotic activity index, and mitotic index score all were significantly associated with worse breast cancer survival. However, only mitotic activity index and mitotic count per tumor were predictive of breast cancer recurrence, while mitotic index was not. As you can see here, all the 3 techniques showed a poor prognostic or a poor, except the mitotic index didn't show insignificant association with recurrence. In a multivariate Cox regression model, adjusted for other prognostic covariate like grade, nodal stage, Ki-67 score, we have found that the mitotic activity index, the mitotic count per tumor, and the mitotic index all were independent predictor of outcome. However, in a multivariate analysis, when we included all the 3 mitotic scores as a continuous variable, we have found that only the mitotic activity index was independent predictor of survival in terms of breast cancer survival, distant metastasis-free survival, and recurrence-free survival, However, mitotic index and mitotic camber tumor were not. And for prediction of chemotherapy response, we have stratified the cases based on the patient receiving chemotherapy treatment, and we have found that only mitotic activity index score was predictive of survival or breast cancer survival in patients who received chemotherapy. Where, as you can see here, it can clearly stratify low and intermediate from high grade scores, while mitotic camber tumor and mitotic index didn't show such association. The results suggest that the mitotic index would be the best and the best effective approach in scoring mitosis during routine diagnosis. Therefore, we focused on the mitotic activity index for clinicopathological parameter correlation and survival prediction. We have found that in the external cohort, the TCGA Nottingham cohort, we have found significant correlation between the aggressive tumor features and high visual and automated both mitotic activity index value. And regarding the association with outcome, both automated and visual mitotic activity index were predictor of survival in Nottingham and TCGA cohort, as you can see in this image. So finally, we have added the automated mitotic activity index to the tubular formation and pleomorphism, but in these we have used the visual tubular formation assessment and pleomorphism score in Nottingham grade, and we have found that there was significant association with breast cancer survival with a higher hazard ratio than the original grade with the visual mitotic activity index score. This highlights that we can reliably use the AI-assisted mitotic scores in clinical practice. As you can see here, this is a new grade when we added the automated mitotic activity index, and this is a conventional grade when we used the visual mitotic activity index in breast cancer specific survival and distant metastasis-free survival. Finally, in this study, we focus on assessing the optimal method for mitosis detection using AI as a prognostic marker and a component of breast cancer grade. The proposed pipeline would be encapsulated into a single software package where it can use AI algorithm to detect mitotic hotspots and estimate the mitotic activity index score. And we found that using the automated mitotic activity index combined with the visual assessment and the tubular formation, visual assessment of tubular formation and pleomorphism, this can form a new digital grade. There are ongoing work involved refining and validating these automated assessment of tubular formation and pleomorphism for incorporation into the whole digital grade. And in this study, we concluded that machine learning algorithms can offer promising and efficient approaches for mitosis scoring in breast cancer and can overcome most of the limitation of visual counting, providing a high throughput output analysis with consistency, and is very likely to be comparable to expert pathologist assessment in the validation cohort. Thank you very much for listening, and I'm open for any questions.
Brilliant. Well, thank you very much, Asmaa, for a really interesting talk. Yeah, it was a fantastic piece of work. So with that, we'll open the floor to questions. Does anyone either online or in person have any questions they'd like to start with? If not, I'll get started then. So my first question is so what do you think are the main challenges in trying to integrate a mitosis detection pipeline, an AI-based mitosis detection pipeline into clinical practice? Asmaa, can you hear me okay? I think we've lost Asmaa. Hi, Asma.
Hi,
Good to
I'm
see you.
sorry, Adam. My, yes, I'm sorry. My internet connection was interrupted. I'm sorry.
Don't worry. Well, it seems to work again now. Did you manage to hear my question or not, or should I repeat it?
No, I didn't hear it. Sorry.
Yeah. So my question really was, so what do you think are the main challenges that can be associated with trying to integrate an AI-based mitosis detection pipeline into clinical practice?
Okay, first, one of these were to how to identify which area to include. And what is optimal area? Was it too many? Because there is a debate whether to use some has proposed using 1 millimeter, some has most of the people use 2 millimeter, and we use the 3 millimeter, and we have done a study before to just assess which area would be the best, and we concluded that 3 millimeter would be the best area to apply this on, and also how to include whether to identify to count within the hotspot area the areas with the high mitotic count or just random areas. And also we concluded that based on the guidelines that counting within the hotspot area would be the best to apply.
Sure.
Okay.
We've also got a question online from, I think, well, Faiz has got a question. He said, "Thank you, Asma. Very nice work. Can you comment on the source of variation or discrepancy across pathologists in mitosis scoring?"
Thank you, Faiz, for your questions. Okay, as we have said, there are different causes for this variability. One of these are the challenging sometimes images where you cannot detect or identify the mitotic figures very precisely, maybe because of the artifacts within the image, some karst cells, some stroma cells can have these hyperchromatic appearance, the metaphase shape of the nuclei. These can be very challenging. Also, as I have said, sometimes where to count. Sometimes people count at the periphery, sometimes people count in the center. So the appreciation of the area where you start counting can lead to difference in the mitotic count. Even the same person, when you score the case, the first time you can appreciate an area where you can start counting, and then the second time you can count in another area. I think the algorithm can help with this because it has like a systematic approach where it can scan the slide at first and find the hotspot area, and then can start counting from there. So it can be more accurate in this regard.
Thank you. We've also got a question from Tilak online who said, "Great presentation. Do you think this algorithm can be used in other cancers as well?"
Yes, of course. It can be applicable in other cancers because, as I've said, mitosis or proliferation is an integral part of any grading of any tumor. Like we have like brain cancer, meningiomas, any other tumors. Mitosis and proliferation are an integral part in their assessment. So of course it can be applied to other tumors.
Brilliant. And I suppose it's the same algorithm as the MyDog 21 challenge, isn't it? It's just, but it's been trained on a different data set, hasn't it? So
yes.
that shows that
Yes.
yeah.
Yes.
Is the model actually the weights or the inference code available online?
Sorry,
I suppose this question is for me. No, unfortunately, so the model is not available because it's under the IP of the university, so we don't have the right to do that. However, we've released the mitosis detections for TCGA cohorts online. So if people want to take those, do similar experiments, or repeat the experiments that Asmaa and I did, they can do that. I'll find the link and post it in the chat here. So if you might ask a question as well.
Yeah.
All right. Thank you, Asmaa, for the really nice presentation.
Thank you, Mustafa. Thank you for your work. Thank you very much.
My question is maybe a little bit unrelated, really. So from clinical perspective, what is the intuition behind partitioning the mitosis-related risk or mitosis counts into 3 groups? So you see, most of the time in survival analysis, we do a low-risk group and high-risk group. But as you did it, and as in most of maybe other mitosis related research, you do low, intermediate, and high risk. Is there any intuition behind this?
Really, it was like it was historical that our scoring was classified into low, intermediate, and high risk. The tubular formation classified the same pleomorphism, mitosis score, and the whole grade. I think this is because sometimes there are like intermediate group. You don't know how they will progress, or the prognosis wouldn't be indeterminate. So I think there should be like an intermediate group. We haven't tried using like two scores, low and high. It can work, but we have tried this using the three-tier system, because it has been historically been a three-tier system.
I see. And do you think this is just specific to breast cancer, or do you think we should follow the same paradigm for other cancer types as well?
I think yes, because most of the cancers are classified. I think maybe the same three-tier systems. Sometimes some of the tumors can be high or malignant or just benign according to the mitotic score. One of the factors that can affect their classification and categorization is a mitotic score. But most of the cases or most of the tumors are classified into three-tier system.
Thank you very much.
Thank you.
Thank you.
So I see Tilak still got his hand up online. Have you got an extra question? Sorry, Tilak.
Yes. Hi, everyone. I'm originally from Nepal. I'm a pathologist. Thank you, Asma. It is great presentations. Right now, I'm working with EI team. As a pathologist, what I can feel, whatever the algorithm is working in one set of data, but it is not working in the other sets. And I asked computer scientists and engineers and all of those people who are working on it, there is this subtle difference can give the different result. But in clinical application, as a pathologist, and regarding my question is focusing towards the mitosis, we usually atypical mitosis would consider we consider it is abnormal. Even one atypical mitosis is there, we consider it lean towards to the malignant, as my understanding. But here we are counting the typical and atypical all mitosis. And do you think it is good idea to separate typical and atypical mitotic ratio to prognostic or any predictive value? If we create this, is there any, whatever your expertise, do you think is it more appropriate than just only counting or keeping the every mitosis in the same basket? Or for me, what I would suggest, if anyone wanted to interest on to work in granular level, let's say to divide into mitosis as a whole mitosis, and what is the ratio of the typical and atypical mitosis. But when the pathology we look at, if there is any atypical mitosis, we consider, oh, it's definitely it is the abnormal. And what do you think about this? This is just my curiosity. It is very innocent curiosity. I don't have any knowledge in computational side.
Yes, it is a very great question. You are absolutely right. There is atypical mitosis would indicate that the tumor is highly aggressive and highly malignant. Mitosis can be found in any tissue. It can be present in any tissue, but of course it is highly prevalent in malignant tumors, and the presence of atypical mitosis are indicative of a highly aggressive and a very highly malignant tumor. It is a great idea to count or to identify the ratio between typical and atypical. It is a very nice idea and can give a very good and significant results where it can categorize somehow the tumors. We don't have enough data on this. We have done some researches on this regard, but without any conclusive results. But it is very good idea to start with. Thank you very much, Tila.
Thank you. Just I was wondering, and then our team, they did this. They used the pre-trained I think the mitotic index algorithm, it didn't work. And you clearly showed, right? It is the mitotic activity index is more prognostic rather than mitotic index. It is not working. I clearly can see the p value is around only it is 0.5, right? So it is very good. It is very promising. Yeah, thank you very much. And this morning I saw your titles, then I jumped to, I'm in from office, right? And then I jumped to this, and your pathologist, it is the great chance to get some ideas. Thank you very much. If I do have any questions, I'll reach out to you, and then I'll read your paper as well. Thanks.
Thank you very much. Thank you.
Brilliant. So we've also got a question from Fires Online, who's asked, do you think we can improve the staining protocol for making the mitosis scoring more consistent?
Actually, it's a very good question. Yes, it has been used in research for identifying mitotic figures using stains like TCGA-3. It is a very good marker that can specifically stain the proliferating cells or that the cells are undergoing mitosis, and it can be used for validation of our results for visual assessment. However, some would argue that it's cost effective. It's very costly to stain each case for just mitotic for just to score mitosis. When I have proposed this idea to other pathologists, they said it's very costly. So we have to just try to select the cases that would benefit from this approach from staining mitotic figures.
Brilliant. So yeah, so Fires has followed up with, I guess what I really wanted to ask was, what are the barriers to adopting triple staining with PHH3? Is it the cost? And I think you just alluded to that towards the end. Yes.
I think just the cost. If it's not costly, it would be perfect to use and would help us very much, and would be no problem with the inter and intra-observer variability. Yes, the cost would be the most significant part. So that's why we would use an algorithm that could count mitotic figures in a cost-effective way and time-efficient way also.
Fantastic. Well, do we have any more questions from anyone in person or online? Alternatively, I'll have a final question. So one of the slides that slightly confused me was the multivariate analysis slide with comparing the three different techniques. So the three different counts. So my question is, why do you think there was such a difference in, say, so I think the hazard ratios there were very close to 1, but they were coming across as significant. But in the previous slide, there was when you included various other variables, the hazard ratios appeared to be larger. So I just wondered why you thought there was, I'm
not sure, but when we first used it, that was like a categorical. It was categorical score, not a continuous score. But when we used them in the same Cox regression analysis model, they were in the continuous.
Right.
Yes.
Yeah. Did you try to then do a Cox model with them categorized as well, then separately?
When they were categorized, they were all significant. So yes.
Okay, thank you.
Okay.
Brilliant. So, any final questions? No, I don't think so. So my final question then is also related to model training. So what sort of domain generalization techniques were used for model training? Was it mainly stain augmentation? Or was that a question for you, Mr.
Yeah, more for me. And so this model being, actually this is the model, the model that Asmaa used was the one we used for mitotic 22. So what we found that the best technique to guarantee generalizations, does not guarantee, but getting the best domain generalization was stain augmentation during the training. So what, in general, one interesting thing that we did, so in this analysis, what we did, we fine-tuned the algorithm. So there are actually two models. So it's the same algorithm, same model. One we use for TCGA, which is basically what we use for mitotic 22. But for the, though I'm not sure which version we used eventually, but I guess we also did another fine-tuned that same algorithm on the annotations that pathologists did on pathway data, the internal validation data. So we did cross-validation and we get much better results because all that data, of course, coming from one domain, you can say they're all coming from one scanner and only breast cancer. And we get much, much better results than what we get on MyDoc data set. But yes, in short, we use stain augmentation as the domain generalization technique and proved to be good.
Oh, fantastic. Yeah, it was a high F1 score, wasn't it? So
Yeah.
brilliant. Well, with that, I think we'll if there's no more burning questions for anyone in person, then we'll draw this seminar to a close. But thank you very much, Asmaa, for giving such a fantastic talk and for answering all of our questions. So just as a reminder for everyone online, so we have our next seminar on Monday, the 5th of February at the same time from 2 till 3 p.m, where we're delighted to be joined by George Wolfline from the University of St Andrews, and hopefully see you all there. And yeah, so thank you very much, Asmaa, for a really interesting talk.
Sorry. Thank you, Adam. Thank you all for your attendance. Thank you.
Thank you. Thanks everyone online.
Thank you.